Hello, this is Dr. Kat Vlies again from Central New Mexico Community College. We're continuing here with the female reproductive system. And in video B, we're going to focus on the internal reproductive structures of the female. The internal genitalia of the female can be divided up into the ovaries, shown right here, which, by the way, are homologous to the testes of the male. And then a series of ducts. The ducts include the fallopian tubes, which carry the fertilized egg into the uterus. The uterus, of course, is also considered a duct because it's a hollow structure. Here's our other fallopian tube, or also referred to as a uterine tube or oviduct. And then the uterus is connected to the vagina. The vagina is a pretty muscular canal, and it has multiple functions. For one, it doesn't just function as the birth canal, but it also is the canal through which the menses leave the body, and it also is the canal of the female into which the penis is inserted so that copulation can occur. It houses several beneficial bacteria, basically bacteria that are absolutely necessary, that maintain a acidic environment in the vagina. And then finally, the canal, the vaginal canal, is not a very smooth canal. It actually has a mucosa rich in rugae, and we've seen that term before. Rugae, we saw it in the stomach. We even had rugae in the collapsed bladder. It also has a smooth muscle layer and then an outer, rather fibrous adventitia. So these are your three layers from deep to more superficial. That brings us to the uterus. Here we see the uterus, and remember the uterus is directly connected to the fallopian tubes, also called the oviducts or the uterine tubes. They use the term uterine tubes here. It is a hollow organ in which, of course, the fertilized zygote will tend to nestle and then develop into a baby. But there's some regions in the uterus to point out. First of all, the main part is referred to as the body. This bump here is referred to as the fundus, sort of similar to how we refer to the bump of the stomach as the fundus. Where the uterus wall narrows, right about here, we refer to that as the isthmus. The connection between the body of the uterus and the vagina we refer to as the cervix. This is typically what is sampled when we females go in to see the gynecologist and have a pap smear done. So cells are collected from this cervix area. And the cervix has two orifices, the external orifice, or sometimes called the external os, versus the internal orifice, or the internal os, and they allow for connection with either the vagina or the uterus, the body or the cavity of the body of the uterus, respectively. The cervix, the wall of the cervix is rather rich in glands that secrete mucus. And that mucus becomes important, particularly at certain times of a female's menstrual cycle. And that is that most of the time during a menstrual cycle, excuse me, the external orifice is pretty crowded with that mucus, making it very difficult for any sperm cells to pass through this plug of mucus. But mid-cycle, typically mid-cycle being the time when we ovulate, that mucus becomes much thinner and it becomes much easier for the sperm to move on up the cervix through the cavity of the uterus and up the fallopian tubes. It is in the fallopian tubes where fertilization between the egg cell and the sperm cell tends to occur. Once again, we're focusing here on the uterus, which is more or less typically pear-shaped, very vascularized, as you see here. Here's the cervix connecting to the body of the uterus, and here we see the fallopian tube with the ovary. The ovary is anchored here with some connective tissue, and all of this beige colored tissue here is again more connective tissue covering these reproductive structures. So we're looking at the posterior side of the uterus and the ovaries, or one ovary. Now, if we look at the wall of our uterus, then we can recognize three distinct layers. The innermost layer is called the endometrium, the muscle layer is called the myometrium, and then the most superficial layer is called the perimetrium. We're going to just focus on the endometrium because the endometrium is the layer that builds up and sloughs off every month and creates the menses in a fertile female. In addition to that, in the endometrium, uterine glands develop and secrete secretions that can help with the development of the embryo. Within the endometrium, then, we see two sublayers, the stratum functionalis, which is the layer that builds up and sloughs off and therefore produces the menses or menstruations. And so this is a layer that responds to different hormones that we're going to learn about. One layer that remains permanent and does not slough off in the endometrium is called the stratum basalis. And so it is not responsive towards ovarian hormones. It's always present. The uterus has its own blood supply, and the arteries that supply the uterus more directly are the uterine arteries, which actually also anastomose with the ovarian arteries. These uterine arteries arise from the rather large internal iliac arteries. You find those in the regions where you find your two iliac bones, very close to the aorta, where the aorta splits into the two common iliac arteries, which then give rise to the internal iliac arteries. The uterine arteries are going to branch and branch and branch and branch, as you see here, throughout the perimetrium, myometrium, and eventually reach the endometrium to form what are called the spiral arteries. And it is these spiral arteries that are formed and break down and formed and break down, or regenerate and degenerate as we build up and break down the stratum functionalis layer of the endometrium. Of course, in addition to arteries, we need to also have veins that drain this whole area, and the veins have sinusoidal enlargements, very characteristic of the uterus wall as well. So let's move on now to our fallopian tubes, or the uterine tubes, or the oviducts, or ovarian tubes, or I think those are all the many synonyms. So far we have studied the vagina. So sperm would travel up the vagina into the uterus via the cervix into the body of the uterus, and then up the uterine tubes. And then hopefully there will be an egg present in these fallopian tubes to be fertilized, which then will create a zygote that can then travel back to the uterus and settle here. Or hopefully not, meaning hopefully there is no egg to be fertilized, and then the sperm cells will literally just end up in the peritoneal cavity and deteriorate there. So the point I'm trying to make here is that the fallopian tubes, your oviducts, are not touching the ovaries. So let's go over the anatomy of the oviducts. So the connection between the uterus and the ovaries is at the beginning slightly narrowed, and from there the term isthmus again. Then it starts to widen, maybe better visible here, and then we call it the ampulla. When a duct widens, often it's referred to as an ampulla. And then finally we get to the infundibulum, basically the stalk, and that has these little finger-like projections that we refer to as the fimbriae. These fimbriae do not contact the ovaries, but they do move around in the surrounding fluid here, and those movements of those fimbriae, plus the fact that the lining of our fallopian tube is ciliated, and the beating of the cilia together with the movement of the fimbriae will draw in an egg that ovulated into our fallopian tube. Again, if fertilization is to occur, it typically happens somewhere in the fallopian tube. Now, the fact that the sperm cells, most of them are literally going to be dumped somewhere in the peritoneal cavity, that does mean that there is a chance that fertilization occurs outside our fallopian tubes, which is not a good thing. Sometimes, that is referred to as an ectopic pregnancy. Finally, we get to the ovaries, of which there are two. And in functioning ovaries, meaning they're going through regular ovulation, we find that they're about the size of an almond. They're held in place by various ligaments, as I mentioned earlier, even ligaments that anchor it to the uterus itself. It has a good blood supply via the ovarian artery and is veined via the ovarian vein. And because there is so much anastomosis with the uterine circulation, we once again see that these ovaries are well supplied. If we take a look at the layers, the histological layers of the ovaries, let's take a look at this picture here. I know this is in a different language than English, but I think you can figure out what most of these terms are referring to. First of all, what we find is that the very outer layer, the most superficial layer of an ovary, as you can see, is simple cuboidal epithelial tissue. You probably studied this as an example for simple cuboidal epithelial tissue back in A&P 1. If we go a little deeper to that, we get to a rather fibrous-like layer called the tunica albuginea. We also had a tunica albuginea in the male's testes. Don't forget that the ovaries are homologous to the male's testes. And so if I had to point that out on this diagram, the layer number one would be this layer here. This is one, and just deep to it would be number two. I'm actually already starting to go into layer number 3, because where you see all of these follicles, small and big, even a very big one here, those are located in the cortex. And then finally, where you see all of these blood vessels in particular, that is going to be referred to as the medulla. Now we're going to learn about all the different phases of these follicles, and the follicles are the ones that hold the eggs, and from in the next few videos we're going to see that we can't just call these structures eggs anymore, because they go through different phases of a meiotic division.